Good evening, doctors. We welcome you all to this informative and interactive show, the Pundit Show by Dr. Ritu Santwani, supported by Innovcare Life Sciences, the makers of metinofol, proinofol, and inofol HB. Myself, Sankalp Sane, the marketing manager. Welcome, Dr. Ritu and Dr. Surika Taide. Welcome, doctor.
Thank you, Sankalp.
About Innovcare Life Sciences, we are engaged in marketing specialized innovative products across the country in the field of infertility as well as pregnancy care. To begin this session first, I would like to introduce our eminent speaker, Dr. Ritu Santwani. Welcome, ma'am. Doctor is specialized in the field of IVF infertility test tube baby, having 20 years of vast experience in the field of obs and gynae. Doctor is a director at Pune Test Tube Baby Center, and doctor is having expertise in the field of IUI, ICSI, IVF, assisted hitching, egg embryo donation, surrogate mother, male infertility, semen banking, embryo freezing, sexual and psychological problems, and try to give moral and emotional support to the infertility patients. So, once I have introduced Madam, I will once again introduce our next eminent speaker,
Yes.
Madam Dr. Surika Taide. Welcome, Madam.
Thank you.
Dr. Taide, Madam is a teacher, trainer, mentor, and facilitator and guide. Madam is a professor and unit head at Reputed Institute of Varda since last 20 years at MGIMS Sevagram. Now at Jawaharlal Nehru Medical College, Varda. Doctor is an alumni of GMC Nagpur, first in the Maharashtra in HSA exams. A recipient of Anand Jivne University Gold Medal, recipient of Savitribai Phule Award for Community Service, presently chairperson of International Organization Women Health Task Force towards Unity for Health based in USA 2020-2022. Madam is a vice chair International Organization Women and Health Together for the Future based in South Africa. Expert committee member and national guidelines for OPS, HDU and ICU. So, doctor, once again, welcome you for this interactive show. Over to you.
Thank you.
Yeah. Thank you, Sankalp, and thank you, Innovacare Life Sciences, for giving the constant support. A very, very warm welcome to my very, very dear friend, a very knowledgeable Dr. Surika. Thank you, Dr. Surika, for accepting the invitation. Before I start the show, from my side, these lovely roses for you as a welcome.
Thank you so much, Ritu, for your love and affection.
Yeah. Friends, as all of you know, in this my Pundit show, I always invite the persons who are very knowledgeable and who always believe in sharing of the knowledge. So, friends, today I invited my very, very dear friend, who we can say Dr. Surika is an ocean of knowledge, and she always believes in sharing of knowledge. So, that is a very, very good point. So before we move to the topic, friends, today is a very, very good occasion of the Ganesh Chaturthi. So a very, very happy Chaturthi to all of you. I want to start with these two lines. Vakratund Mahakaya Suryakoti Samprabha Nirvigne Kurume Deva Sarvakareshu Sarvada. A very, very happy Chaturthi to all of you. So with your permission, Dr. Surika, can we start our happy virtual hour?
Yes, definitely. We are eager and energetic to start.
Yeah, thank you so much. Dr. Surika, in this webinar, I'm going to ask you some basic questions also, because this webinar is attended by across the globe from some young budding gynecologists also. So we are taking some questions very basic also and some the advanced, on which you are the master. So please don't mind. I'm going to start with some basic questions also.
Okay.
Yeah.
Definitely.
So, friends, as all of you are aware of this PPH, and today we are going to discuss with regarding this mystery of PPH. So, Dr. Surika, I want to know your opinion. Is to classify PPH is very important when the patient is actually bleeding heavily at the time of the labor?
Yes, Dr. Ritu. See, there are various classification of postpartum hemorrhage. Yeah. And one of the simplest classification is when we classify the postpartum hemorrhage as a primary postpartum hemorrhage when the bleeding occurs within the first 24 hours after childbirth. And the second is the secondary PPH when there is a delayed sort of bleeding after 24 hours till 6 weeks of pregnancy. Now, in both the things, the etiology is different. Like in primary postpartum hemorrhage, the etiology will mostly be a atonic uterus or a trauma to the uterus, or it could be a mixed variety. there could be retained placental bits, there could be uterine rupture or uterine inversion, or also there could be a blood coagulopathy. But if you look at the secondary postpartum hemorrhage, then it could be because of infection, or maybe some retained cotyledon, or there may be some endometritis, subinvolution. So if you classify, then you know what kind of etiology there will be, and depending on the etiology, we can define or we determine the most suitable line of management. Apart from this classification, which is a very basic classification, there is another classification of hemorrhage depending on the amount of bleeding. Like we say hemorrhage class 1 hemorrhage, class 2 hemorrhage, class 3 and class 4. So if you say class 1 hemorrhage, the blood loss will be less than 900. If in the class 2 hemorrhage, the blood loss will be between 1200 to 1500. And in class 3 hemorrhage, between 1800 to 2100. And if it is more than class 4, more than 2400, that is more than 40% of our body, the blood is lost. So now, depending on this, we are going to have various sort of clinical symptoms also. Like in first two classes, we're not going to have a lot of symptoms, maybe a little bit of tachycardia and respiratory distress. But in the class 3 and class 4, you're going to have, signs of hypotension. So overt signs will be there when there is lot amount of bleeding. There could be cold, clammy skin. There could be tachycardia, hypotension. Profound shock will be there in the class 4 hemorrhage. So if you classify, then you'll be able to tell what kind of, what kind of intervention you are going to do. Like in first class and 2, you're just going to observe and give some replacement therapy in the form of intravenous fluid. But if in the second and in the third and fourth class, you're going to actively manage the case. So that is why it is very important that you have this knowledge of classification.
Yeah. Thank you, Dr. Surika, for such a very nice explanation. Now, a very important query. जितने भी young budding gynec होते हैं, जब उनकी labor room में duty लगती है, so that is a very, very important query in all of their mind, that how to estimate the blood loss. What are the challenges they find? Do you suggest any protocol for this managing, and how do they estimate the blood loss?
Now, if you really remember our residency days, you must be knowing that, usually it is not a quantitative type of estimation which we do. It is only a visual estimation. And let me tell all the audience that this visual estimation is actually a gross underestimate of what is happening. Till we know that the patient has landed into a large amount of bleeding, she actually progresses into shock, because we don't do a quantitative type of estimation. So there are various methods by which we estimate. Less modern methods will be like soaked pieces, how much it is soaked, and the traditional birth attendants will use the kangas. So kitna soak hua hai, that we will try to. So rural setting में हम लोग इस तरह करते हैं. But now what we recommend is calibrated drapes, जिसको हम brass V drapes कहते हैं. So these brass V drape will be under the buttock of the patient in case of a vaginal delivery, and all the blood will be collected in that. Okay, so we have to create, a list of what all has been soaked. Okay, so it could be the clothes of the patient. It could be, and then we should begin quantifying this blood loss. So we should also remember that a lot of fluid which we see in the labor room would be the placental fluid, amniotic fluid, could be urine also. If you are irrigating or using something, that also could be there. So we have to estimate. If we have that brassy drape, and easily you could do it. Now, if you try to estimate in a cesarean section, then you have to, I hope I'm audible.
Yes.
So in case of a cesarean section, you have to begin the quantification after you give incision on the uterus. Okay, and first of all, you have to allow the amniotic fluid to go off, and then so you can have 2 suction machines. one suction machine is just sucking out. So, and after the placenta is separated, and then whatever gets collected in the suction, in the tube and in the canister will all be blood. Apart from that, you could also weigh, your whatever soaked sponges are there. So 1 gram of the soak sponge equals to 1 ml of the blood. Okay, so in that way you could quantify. So all the suction what you have collected, and then weigh all the soaked sponges, and accordingly you convert into how much is the loss. Now this is this is the sort of quantification. Now in modern era, what is available is artificial intelligence enabled technology. These platforms are now coming up. These artificial intelligent platforms are mobile technology. What we do, you just click whatever is soaked by the mobile, okay, and the picture is taken of the surgical sponges and the canisters, and the mobile app performs a calorimetric analysis, and the images are uploaded to a cloud-based machine, and from that program also you are able to estimate how much is the blood loss. Now these are all learning lessons for us, that only visual estimation is not good enough, and we have to train ourselves so that we can quantify the blood loss in a proper way, so that we are alert and into action before our patient goes into shock. I hope that I am clear. And
yes. Very nice and very crisp answer. Before I proceed to other question, let me welcome all the members. Dr. Surika, doctors have joined all across the India. Dr. Kiran Sena madam has joined, Secretary of Kanpur Society madam is also joined. Dr. Sabita Agarwal is joined from Allahabad. So many doctors have joined from Lucknow, Bhopal, Katni and Indore. अभी तक मुझे इतना दिख रहा है, बाकी फेसबुक से जो ज्वाइन हुए होंगे दैट्स अ डिफरेंट. Yeah, so welcome.
Nice.
So welcome all of you friends. So now my next question to you, Dr. Surika, as you are an excellent professor, so your answers are very, very nice. And later on, I will request you if you can share with us some crisp points at the end, so we can publish that in the Facebook also. What you are telling is very, very nice. That will be beneficial to all. क्योंकि आप बहुत ही अच्छा बता रहे हैं, ये पॉइंट्स कुछ नोट करके मतलब जितने भी यंग गायनेकोलॉजिस्ट हैं उनके लिए बहुत हेल्पफुल रहेगा. So Dr. Surika, my other question to you. Welcome. So my other question to you is, there any factors from that we can predict the PPH antenatally and intrapartum?
See, as far as PPH is concerned, we say that this is unpredictable. Obstetrics is unpredictable, we say. But any patient can land into PPH, and even if a normal patient is walking into the labor room, and she can also land into PPH. But there are certain risk factors which, if we note down in the antenatal period and the intrapartum period, then we can be more alert. Okay, this patient may land into PPH, and I have to be alert for this patient. Now, there are certain demographic factors which we should be aware of. Like if you are non-white, I mean, Asians are also prone. So non-white ethnicity is one. Older age is another very important demographic feature. Fertility enhancement, those patients who are going through this. So these are a little older age, and they are also at high risk. Certain antepartum risk factors are like if she has a history of PPH in a previous pregnancy, that becomes very important. Any blood disorders, if she is a grand multipara, if she is having high blood pressure, multiple pregnancy, history of antepartum hemorrhage, placenta previa or accidental hemorrhage, then if she doesn't take her iron tablet supplementation well and she's anemic, if she's having an over-distended uterus because of polyhydramnios, or if she's quite obese with increased BMI, these are very important antenatal risk factors which we should know. Apart from that, there are certain intrapartum risk factors also, like your labor augmentation if you have done, induction of labor if you have done with either an oxytocin or a prostaglandin, and abnormal fetal presentations, uterine atony if she's having some coagulopathy. So again, birth weight is high. Then again, so apart from that, prolonged labor, if your labor is lasting for more than 12 hours, so that also becomes a risk factor. So all these risk factors alone, that risk factor may not be predictable, but if you combine this predictive value of this alone, if it's a risk factor, it is low. But if you combine the risk factors, if more than 4 risk factors are there in this patient, like she's having hypertension also, she's eclamptic, she's having anemia, she's older age, so she becomes a very high risk patient. So in this way, we can predict, and then we can be alert, and probably we can take some measures that could prevent these patients landing into PPH.
Yeah. Thank you very much. My next question is coming on that only. As we always say that prevention is better than cure. So please share some practical tips for the young gynecologists that how can they actively do the prevention of PPH?
Yes. So as far as PPH prevention is concerned, presently I have shared with you all the risk factors. If we categorize this risk and be aware that yes, this patient is going to land into PPH. Now, during our antenatal period also, if the patient is anemic, we should improve the health status of the patient. You should concentrate on improving and correcting the anemia. Maybe if it is not getting corrected with oral drugs, you may give injectables to her, but we have to take her to an appropriate level where she'll be able to bear whatever blood loss occurs during labor, either a vaginal delivery or a cesarean section. Secondly, if you are having high risk patients like a twins or a hydramnios, a grand multipara, or somebody who is having accidental hemorrhage, bleeding during the antenatal period, previous PPH patient. So these patients you should definitely have a institutional delivery where there is a team available who can take care of her. So thirdly, what we called as birth preparedness. So blood grouping, RH typing, one blood should be ready so that if she needs. So these high risk patients, we have to be alert. And another very important thing, nowadays we are finding a lot of patients with previous cesarean section, and these previous cesarean section have a risk of having placenta accreta. So localization of this placenta by ultrasound, very nicely looking at the placental myometrial interface so that we are able to judge if there is an accreta. And if we are finding accreta, then you go for an MRI, and then you are very much ready for these patients who are going to land into PPH later on. And you make a plan, yes, this patient may land in PPH. If she's an accreta, then totally the management changes. So in this way, we can go about. And again, in the intraprenatal period also, if you're inducing a patient with oxytocin and the labor is prolonging for a long period of time, then yes, this patient can land into PPH. And lastly, I would also talk to you about, and the audience about, after the childbirth. What happens? We are very much alert till the childbirth, but after the childbirth, that the after the childbirth, observation for at least 2 hours strictly after delivery. So we have to train our the staff nurses and attendants in the labor room to monitor this patient, not to leave her, because if she bleeds in that particular, so being alert whether the uterus is well contracted, what is the amount of bleeding, is there a trickling going on. So all this is considered as a preventive step. Apart from that, evidence says that active management of third stage of labor. We have been taught in our residency. When I was a resident, we used to use methargine. If you remember. For management. But now WHO has changed the protocol. Now WHO is saying use oxytocin. Oxytocin, 10 units, international units, intramuscularly after the baby is born. When I was a resident, we used to be taught methargine at the birth of anterior shoulder. But
yes.
now we are saying oxytocin intramuscularly after the baby is born within 1 minute. Then deliver the placenta by controlled cord traction method and delayed cord clamping and massaging the uterus. These three components form active management of third stage of labor. All patients should undergo this active management of third stage of labor. And if oxytocin is not available, then misoprostol also can be used as an active management of third stage of labor, which we give 600 microgram per rectally.
Yeah.
So these simple measures, if we train ourselves reflexly to do this and train our staff to follow this protocol, probably we can prevent PPH.
Yeah. Thank you so much, Dr. Surika, for a very elaborate explanation. Friends, those of you who have joined via Facebook, YouTube, request to you, please write your questions there. Please don't send me the questions personally on the WhatsApp. It's very difficult to copy paste from there. You can post your questions on the YouTube and in the Facebook. Our technical expert, Mr. Vaibhav is there. Vaibhav, the questions are coming. Please copy paste here. Later on, all complain to me. हमें ये question पूछना था, मैम आपने हमारा question नहीं लिया. This is happening from last 3 times, Dr. Surika. सब बाद में मुझे लिखते हैं, मैम आपने हमारा intentionally question नहीं लिया. So with WhatsApp is very difficult.
Show is very popular.
No, thank you. Because I am having a stalwarts like you.
Thank you.
So yeah. So now I'm, as you already told regarding this oxytocin, is it the some entity other also which includes this bundle approach for the PPH management?
Yeah, so see, till now we have been taught about active management of third stage, use of oxytocin, use of methargine, but we have heard less about the bundle approach. What is the bundle approach? Recently, only in last 2-3 years, we are hearing about this bundle approach. Now, these care bundles have been used to deliver high quality of clinical care, depending on what are the best practices, what are certain improvements which have taken place. And so these bundles or care bundles, they provide adherence to certain clinical guidelines and protocols. So if you have a guideline, if you have a protocol, and then depending on that protocol, these bundles are devised. These are nothing but packages or checklists. Like we say AMTSL. What is active management of third stage? 4 things. We teach everybody 4 things: oxytocin, massage, and control cord traction. And so like that, bundle approach is nothing but a checklist which we should follow correctly. And this approach actually has come up now. Initially there was a prevention bundle, like I told you now, and now management bundle contains of 2. One is called as the first response bundle, and another is called as a response to refractory PPH bundle. First response means as soon as you judge that this patient is bleeding heavily and may land further into a class 3 type of hemorrhage, then you initiate this bundle, which contains the uterotonic drug like your oxytocin, methargine, or carboprose. So you initiate that. You start crystalloids like your intravenous ringer lactate. Then again, very important, we have to note that we can give tranexamic acid. Tranexamic acid हमको हमारे रेसिडेंसी में नहीं पढ़ाया गया था, but now it has come up in the last 2-3 years as a very good drug which should be given within the first 3 hours of PPH. उसके बाद में वो कुछ काम नहीं करता है. Okay, so initial, and then again you try and massage. So 4 things are there in the first response bundle: your oxytocin, your crystalloids, tranexamic acid, and massage. This forms the first bundle. Now, if your patient doesn't respond to this management and her PPH, your bleeding goes on. So that is called as a refractory PPH bundle. When your patient is not responding to the initial resuscitation, your oxytocin, then you go to the second bundle. Now, in the second bundle, you have certain compression measures like aortic compression, bimanual uterine compression, inserting a balloon tamponade, using a Nasg Garment. So all these are the next bundle. So if you follow systematically and structure the management, that is called as a bundle approach. So if you allow me to go into the scheme of management, then I will go ahead and let you know, let the audience know how to structure the PPH management also.
You can go ahead. Yes.
So if you talk about structuring, WHO has given this structure very well. You know what to do immediately. If you find a patient is landing into PPH, अभी patient bleed हो रही है, आप अकेले हैं, क्या करोगे आप? Are you going to manage that patient alone? No. First thing to do is call for help. कितने लोग आपके पास और अवेलेबल है? आपके बाजू में कोई नर्सिंग होम में आपके कोई दूसरे डॉक्टर है? Whether that person can come and help you, or whether your nurse who is trained can. So first is call for help. Second is secure the IV line. एक ही IV line लगी है, 2 IV line लगाइए. That should be 2 wide bore cannulas. और blood आपको send करना है, आपको arrange करना है for your blood and blood products. Rapidly infuse IV fluid. 2 लीटर तक तो आपको ब्लड लगने वाला है, ये सोच के आपने अरेंज करना है. ब्लैडर कैथेटराइज हुआ है कि नहीं वो देख लीजिए और मॉनिटर करिए पल्स, ब्लड प्रेशर, टेम्परेचर. आउटपुट बहुत बार लोग भूल जाते हैं कि आउटपुट आ रहा है कि नहीं आ रहा है. एंड देन you have to decide whether it is an atonic PPH या traumatic PPH. हम लोग हमारे रेसिडेंट्स को क्या सिखाते हैं? Keep your hand on the uterus, abdomen. अगर आपको लगता है कि atonic, if it's not a hard uterus, then you will say, okay, this is an atonic uterus. But if you find the uterus is already hard, that means there is some trauma. Go and do a speculum examination, do a local examination. Is there a laceration? Is there a cervical tear which you have mixed? So you try to classify whether it is atonic, whether it is traumatic. और अगर atonic है तो then आप मसाज कीजिए, आप oxytocin you should give. Then you should also give initially you add oxytocin 10 to 20 units in 500 ml of ringer lactate. Or you could give an injection methargin, which is 0.2 milligram intravenously slowly, and then of course you find out whether the patient is responding to your drugs. Otherwise, you can also give carboprost or misoprostol, and then decide whether there is some response or not. If there is no response, you can go for the balloon tamponade. You could go for bimanual compression. And you could go. Then after this, you can reassess. If she's not responding, then you have to go for surgical management. And on the other side, if it is a traumatic PPH, then of course, if it is trauma, then you have to repair. So this is a very systematic way of going through a bundle approach and a systematic management of PPH, so that you don't miss anything and you follow all the steps correctly, so that your patient benefits immediately. So because that is called as a golden hour. Within the first hour, you have to do everything so that your patient can survive.
Yeah. Thank you so much, Dr. Surika. Dr. Surika, one very practical query comes in my mind. As you are attached with this medical college, so these days, are you giving the training to the residents for this balloon tamponade also?
Yes. Let me tell you that when I was at Mahatma Gandhi Institute of Medical Sciences, we had a project with Harvard University. Dr. Burke was the one who brought this balloon tamponade, and his device is known as ESM-UBT. Every second matters, uterine balloon tamponade. And we did this project in 10 medical colleges around our area, and we tested this balloon. So we not only give this training to our residents, but also to peripheral health workers, like people from the district hospital, because they are going to refer that patient to us. People, we also went to various villages around our district and trained the primary healthcare workers, like the staff nurses, the ashas, the medical officers. So everybody was trained in using the balloon to manage PPH. And I can tell you by my experience as a trainer that using a uterine balloon is very easy. And the device which Dr. Bark has developed, which is called as the ESM UBT, is very simple and very low cost. It costs only 100 to 150 rupees, and the government of India also has taken up the design, the production of this. It is a simple Foley's catheter, and there are two, like Foley's has two channels. The two channels are there, and there is a condom. It's a good quality condom which comes with the packet, and that condom is placed over the Foley's catheter in such a way, and then you tie it in, and this is in such a way that once you inflate this balloon with normal saline, then it will take up the shape of the uterus and compress all the bleeding vessels. Apart from that, it also acutely compress the uterine vessels because of the position, which it attains after the balloon inflates with that amount of normal saline. So all the vessels get compressed. So it's a very good device which we are training our people, and this training we are taking into other states also, like Madhya Pradesh and UP. Now Mahatma Gandhi Institute is taking up this project. UBT is a very, very good device, and if it is not available with the practitioners, they can use their routine Foley's catheter and routine condom. They can tie and they can prepare their own balloon catheter.
Thank you so much, Dr. Surika, for sharing such important practical tips. I think the purpose of this show is the discussion of the practical tips. Theory to सबको ही पढ़ सकता है, but this what you are sharing, the very practical tips, is very, very important. One another query come in my mind, Dr. Surika, when we are studying 20 years back. So that time only the prostadine was launched. So means what I learned from my teachers, I was a student of Professor Chandravati. That time we believe in giving more in the intramyometrial prostadine. So what's your experience? What you think that it is intramyometrial is more better, or you prefer the intramuscular for this
happens, let me tell you, when it is a sort of when there is a PPH, you remember that it is a panicky situation.
True.
And to avoid that panic only, we are devising this structured approach. Okay, so if you are talking of oxytocin, first thing I recommend is start an oxytocin drip, which I have already said 20 units. Then we are talking of carboprost. Now, if it's a vaginal delivery, you prefer that you give an intramuscular dose, okay? But WHO is not saying that you cannot give an intramyometrial. In fact, if you are doing a cesarean section and the uterus is already in your hand and it is like, like a sac, not contracting at all. So you could give an intramuscular as well as a intramyometrial. Okay, so that will work actually. So if it's a vaginal delivery, then usually we prefer that we give an intramyometrial dose, and if required, then repeat the dose after 15 minutes. And of course, if it's a cesarean section, I would prefer that we use the intramyometrial. So that is my experience, which I am sharing with you.
So there is one query by Dr. Surya Kumar. He's asking, as you have mentioned this transrectal use for this misoprostol. So he's asking your experience regarding the use of sublingual use of misoprostol.
Now let me tell you, if the patient is in shock, okay, if she's in shock, then usually we would not give anything orally.
Yeah.
And of course, you cannot give vaginally. So that is why the WHO has recommended that we should give it per rectally. The absorption is also good, and if you are giving sublingually in a patient who is in shock, who is not responding to your commands, then it is not a preferred route. So per rectal is a preferred route.
Yeah, thank you so much. My other question comes regarding this, as you already mentioned this regarding MRP also. So MRP versus intra-umbilical oxytocin, what's your opinion on
now
this?
If you're talking of MRP versus intra-umbilical oxytocin, when I was a resident at that time, this new research was coming up that you can give a intra-umbilical oxytocin, and the placenta is going to come out. Now we know that manual removal of placenta involves an operative procedure where the patient has to be taken to the operation theater, and you have to give a relaxing anesthesia so that your hand can be inserted inside the uterus and you can remove the. Now this is a sort of an invasive procedure. So people have tried to develop certain non-invasive. They do not want the patient to take the patient to the OT. So they have tried in injecting oxytocin solution in the umbilical cord, and this is considered as a simple and inexpensive technique. But there has been various trials whether this is really beneficial or not. If you look at the reviews, there have been more than 15 trials, and more than 2,000 women have been involved in this. But they are not able to prove that really it is beneficial. 50% of time, the retail placenta is going to come out on its own if you give a little bit of time. And even if you use simple measures like emptying the bladder, nipple stimulation, the patient may respond. But as it is a very simple procedure, very inexpensive procedure, we have been using it, and many a times we see good results that yes, giving oxytocin may prevent that surgical intervention which we want to avoid. But we have to judge. You cannot wait too much period of time. You give the umbilical oxytocin, and after that you can judge whether okay, this patient is responding or not, and you can ascertain. In my residency, I have given, and if there is a retained placenta, even now we are recommending. But whether it is just a placebo, if you just insert saline, also whether the placenta is going to come out, these are the points of research, and still the research is going on this.
Yeah. Thank you so much. Dr. Surika, I want that you should enlighten us regarding this, what earlier we are doing in the surgical management, the cesarean hysterectomy. So what's the current scenario? Please enlighten us about that.
See, if you talk of surgical management, there are various types of surgical management. Hysterectomy is considered a radical approach. Okay. Before that, also there are various kind of procedures. First of all, we should know procedural skills. What are the procedural skills we can first use? Like aortic compression. I don't know whether our audience is aware that if you apply a correct aortic compression, that may help in reducing the blood loss. A correct bimanual compression. So what we say, a procedure, you put a fist inside, put your hand inside the vagina, go in the form of a fist, and then press the uterus in between your hand, which is on the abdomen, and one which is in the vagina. Press the uterus between the two tightly. So that is called as a bimanual compression. then a proper tamponade, a proper NASG. Okay, so these are procedural skills. And then when you go to surgery, also there are two types of surgeries. One is a conservative surgery, another is a radical surgery. If you say conservative surgery, there could be some compression sutures like your B-Lynch, then there could be stepwise devascularization, what we call as uterine ligation, ovarian ligation, and then lastly we could go for last approach could be the hysterectomy.
Yeah.
But let me tell you, there are certain situations wherein we may go directly for hysterectomy and we may not keep it last. Okay,
Yeah.
so lastly, there are certain situations where hysterectomy is considered the primary approach. जैसे अभी किसी को internal iliac अगर कोई setup में people are not well versed with it and they are not confident that they'll be able to do an internal iliac ligation. So whether they should wait for some person to come and do it or whether they should go for quickly doing a peripartum hysterectomy and save the patient. So these are certain things which we have to remember, that saving the life is very important. So if you can conserve, then it is fine. But if there is a situation where you have to directly go for your hysterectomy, then you have to take that decision. So doing the surgery is not important. I always say that hysterectomy तो किसको भी करना आ जाएगा, क्योंकि gynecology में जो hysterectomy करती है उससे भी आसान hysterectomy peripartum hysterectomy हो सकती है. But taking the decision that yes, this patient has to go for hysterectomy, you cannot wait for all the conservative management. That is actually a skill, and that is where our grit and our training comes into benefit is there of proper training and knowledge sharing.
Yeah, thank you so much. I want to share with you, Dr. Surika, Sushma Bakshi madam has also joined with us, and madam is congratulating us. Let me inform you also, or I can share with all. I have done one show with Sushma Bakshi madam also on the menopause, mystery of menopause. That show was also a very, very grand hit. We got the 3,200 audience live at that time. Yeah, and so thank you, Sushma ma'am, for joining and always encouraging us. There is one question by Dr. Hema Jaju. Dr. Surika, I'm taking questions in between as already we have exceeded our show time. You are informing us so nicely. So, there is one question by Dr. Hema Jaju. She is asking oxytocin to be given in uterine artery.
Umbilical vein. It is the umbilical vein.
Umbilical. Sorry. I
umbilical vein.
Yeah. Umbilical.
So we are talking of the cord.
Yeah.
You have to remember that there are two arteries and one vein.
Yeah.
And where we have to identify, the vein is identified very easily. So we give in the umbilical vein.
Yeah. Thank you. So my other question, as you already very nicely explained for this, can you this regarding this radiological management these days is coming. अभी वो सारी जगह तो नहीं है, but it is mentioned in somewhere.
नहीं, रेडियोलॉजिकल मैनेजमेंट का क्या है, मैं आपसे शेयर करना चाहूंगी कि यहाँ पे इंटरवेंशनल रेडियोलॉजी अवेलेबल है.
True.
So these are the setups where we could go for radiological management. In my institute in Jawaharlal Nehru Medical College, wherein I am, interventional radiology unit is very nicely set up. And of course, in many corporates also, it has come up. In AIMS-like institutes and AIMS it's there. So those setups, it should be an institutional setup. So what is interventional radiology is uterine artery embolization. So this is a selective artery embolization wherein gelatin sponges are injected into the bleeding vessel until the stasis of flow in the target vessel is achieved. Now, ये एक्सेस कहाँ से मिलेगा इन वेसल्स के लिए? तो femoral से usually femoral से जाते हैं, from femorals to internal iliac and subsequently to the uterine arteries very nicely. They cannulate these vessels and they put the gelatin sponges so that that target vessel is blocked. Advantages of this selective artery embolization is that it preserves the fertility, and especially useful if it is a placenta previa or an accreta. However, there are certain disadvantages कि वहाँ पे आपको रेडियोलॉजिकल एक्सपर्टीज की जरूरत है, 24 आवर ये अवेलेबल होने चाहिए रेडियोलॉजिस्ट. PPH तो कभी भी हो सकता है, in the middle of the night if it is happening. So whether your interventional radiologist is available at that time, and your patient should not be completely in shock. So if your patient is stable, then only you can go for uterine artery embolization. Sure. Otherwise, it is better that you take the patient to the operation theater and do the cesarean hysterectomy or other procedure. So you have to take the decision. And there could be certain other adverse effects also, like local hematoma हो गया जहाँ से आपने pierce किया femoral के वहाँ, या फिर necrosis of uterine wall. So these are certain disadvantages. But definitely where there is an expertise, where there is already radiological interventional radiological unit very nicely functional, then you could go for these uterine artery embolization.
Thank you. Thank you so much. Dr. Surika, already we exceeded the time, but I want to know some tips regarding this massive transfusion protocols. I think that is very important.
Massive transfusion, what is the meaning of massive transfusion? First of all, we should know. Okay, so when we say massive transfusion, we are talking of a large amount of blood which is given, and we say either 10 units of blood have been transfused as a whole within 24 hours, or within the 4-5 hours you are giving at least 5 units of blood. So we should start this transfusion if the hemoglobin levels are going very low. In fact, the recommendation is that as soon as you find that hemoglobin is going less than 7 grams, so 6 grams, 5 grams, so you should start this massive transfusion protocol. Now we should remember that we are not going to give only whole blood. तो हमको कैसे लगता है कि transfusion यानी सिर्फ whole blood. So it's not like that. So apart from the whole blood, we have to give the fresh frozen plasma, and we have to also give the platelet. So now the recommendation is that this has to be given in the ratio of 1:1:1. So if you have given 1 blood, then you should also give 1 one fresh frozen plasma and 1 platelet. So remember that it is not only the blood, we have to also transfuse the fresh frozen plasma and the platelet, because these are the this will contain all the coagulation factors which are necessary that your patient should improve.
Yeah. Thank you.
But remember that when you are initiating a massive transfusion protocol, you have to take proper precautions, that there should be proper cross matching. In a state of panic, it should not happen that you are not properly documenting what kind of blood you have given, and screening of the blood is important. And remember to monitor the patient after this massive transfusion. Sometimes you may have a complication which is called as TRALI. TRALI is transfusion associated acute lung injury. Okay, so if you give massive amount of blood, and there is this transfusion associated injury may be there, so you have to manage this patient in a setup where there is a either an high dependency unit or a intensive care. Okay, so ICU care this patient is going to need. So this patient has to be monitored. So after the event has occurred, then the monitoring and supervision has to be in a HDU ICU setup. Okay, so unless you are having this proper monitoring, your patient may not come out as a successful outcome.
Yeah. Thank you. Thank you so much. Mr. Vaibhav, is there any questions via Facebook or YouTube? Then please paste here. Meanwhile, Dr. Surika, can you want to share us some tips for this regarding Nasg Garment?
Yeah, see, I don't know whether any SG is currently available with our in government setup and also with private practitioners. But NAHG is a very, very important system. It's a device actually. It's a very simple device that counteracts whatever shock is there. You know, because of the shock, what happens, all the blood gets accumulated in the lower extremity. This garment, let me tell you, was developed by NASA almost 20 years ago, and it was also used in the Second World War and the Second World War for the soldiers, where they used to be get injured. Now this is a very useful first aid tool which keeps the woman alive if there is a prolonged transportation. अगर पेशेंट पेरीफ्री से आपके पास आ रही है या फिर आप प्राइवेट प्रैक्टिस में हैं और patient has gone in severe shock and you want to transfer this patient in a good condition from your private practice to a institutional setup, then I recommend that all the private practitioners should have this NASG, which is called as a non-pneumatic anti-shock garment. It should be there in your hospital. What happens physiologically, there is a shunting of blood to the vital organs because you apply that compression on the leg, on the thigh, and on the calf, so all blood will go towards the heart. So this is made up of a material which is called as neoprene or velcro, and there is a lot of evidence that it is a very good device and I think it's a very good investment. Everybody should have this. Okay? Very easily and very quickly applied. Also, hardly 2 minutes you can apply it, and anybody can apply it. It doesn't need a doctor. You can train your nurse, you can train your attendant within 2 to 5 minutes of application. Most patients with severe shock also will regain consciousness because सारा blood जो इधर pull up हो गया है, that will go towards heart and vital organs will begin to receive the blood, and vital signs will start. Vital signs begin to stabilize if you use this NASD. I think in the emergency department it has been used for long years, but obstetric practice, it is still not come into हमारी जो है भी बहुत अच्छे से इस्तेमाल नहीं रहे हैं because I think some available patterns there and people are not aware that it's a really very good sort of garment. Less expensive, very simple to use, can be taught to your nurses and your attendants also, and with this garment you can transfer the patient to the to your institute, and it's really very good. My NASG has to be there in all the steps. So if it is from district hospital to there,
I think Dr. Sureka's network is creating some problem. So thank you, Dr. Sureka, for sharing such a very, very important topic and very important tips with us. So, friends, again, lock your Dr. Surika, are you there?
Yeah, 1 minute. Let me see.
Yes. Meanwhile, Dr. Sureka is joining. So, friends, tomorrow again we are meeting at 9:30 p.m. and discussing a very important topic on this hypertensive disorders in pregnancy. Tomorrow I am having my teacher, Professor Anju Agarwal, with me as a pundit. So, do please join. Yes, Dr. Sureka, are you there?
Yes. So, do you find me? Am I there?
No, I can hear you, but you are not seen, not visible. Your video? Vaibhav, is there any questions? So I think there is some problem. So friends, before I wind up again, I want to say that this is a very auspicious week of this Ganpati festival, and this Ganpati festival is, as all of you know, is started from Pune. It is having a very good history of this. The Ganpati festival is started from Pune. So I want to end with these two lines before I give this to Sankalp. 1 2 3 4 गणपति की जय जयकार 5 6 7 8 गणपति है सबके साथ. I think this we all जब से हम बच्चे से बड़े हुए हैं, हम सब जब भी गणपति फेस्टिवल आता है, though we all are so depressed due to this corona pandemic. So, पर एक बार गणपति फेस्टिवल आने से वापस से एक बार सबके मन में एक बहुत सा उत्साह है और बहुत ही कुछ ऐसा हम एक्सपेक्ट कर रहे हैं कि समथिंग विल बी गुड टू बी हैपन सून. विघ्नहर्ता हैज कम नाउ. बापा हमारी प्रॉब्लम्स को जरूर दूर करेंगे. या ओवर टू यू संकल्प.
Thank you so much, Dr. Ritu. Ritu madam, thank you so much. Indeed, it's a auspicious week, and all are still in this scenario also.
Yeah.
In such type of scenario, the people are still ready to enjoy.
Yeah.
And ready to celebrate, rather, I would say enjoy.
True.
Madam.
Yeah. Yes. Thank you. Yeah. Thank you so much, Dr. Sureka. I thank you from bottom of my heart for sharing such a immense and good practical tips with all of us. So मुझे तो लगता है कि मुझे आपको टीचर्स डे वाले वीक उसमें बुलाना चाहिए था. सितंबर वाले मंथ में बुलाना चाहिए था. मीन सितंबर मंथ वी आर सेलिब्रेटिंग ऑल विद द टीचर्स. So 5th September we are doing with Dr. Pai sir, and 6th we are doing with Nandita ma'am, and 12th we are doing with Rishma ma'am. So thank you once again. We are not having any questions as they told me. So thank you once again. Yeah.
Thank you very much.
Yeah. Thank you to Sankalp, Mr. Sankalp, and Mr. Harish and Innova Care Life Sciences for constantly supporting this program.
Surika